Hello, I am Flavio Ribichini, and I am pleased to welcome you to this new PCR webinar entitled BIO PCI. This is the turning point of vascular interventions. This is a webinar supported by an unrestricted grant from Biotronic. And if you are on the other side of the screen, it's because you want to discuss the rationale of a PCI strategy with minimal stent as a turning point of vascular interventions. Furthermore, we will review the evidence and the ongoing studies with the latest technologies. And we will also analyze and observe and discuss real-life cases with long and very long-term results with bioresorbables technologies. Today, with me in the studios in Paris, it's a pleasure to work together with Professor Piera Capranzano from the Ospedale Ferrarotto in Catania, Italy, Dr. Salvatore Brugaletta from the Hospital Clinique de Barcelona, and Dr. Juan Iglesias from the University Hospital in Geneva. We want to make this as interesting and as interactive as possible, so you have the opportunity of sending me the questions that you will be writing in the web. I will get your questions in this nice iPad, and we'll do our best to come back to your points. So we will start with the objective of this day. Is there a need for an alternative to drug-eluting stents? Drug-eluting stents perform very, very well in certain instances, like in large vessels, in short lesions. We need them in resistant fibrotic calcified lesions, but there might be other circumstances in which they are not really offering the best opportunities. These are small vessels, long lesions, some complex bifurcations, some long CTOs, and in some cases of acute coronary infarction. So just to give you an example when stents are not good, you see this case with the recurrence on the proximal LAD and proximal circ, and a focal subtotal occlusion of the mid-LAD after extensive metallization of the vessel. So this is not a good outcome, and probably it would never be a good idea to metallize all these diffuse small vessel, long LAD vessels. So at this point, I will handle to Salvatore to show us a case where stents are not under discussion.
Yes, and thanks, Flavio. So let me back to 2013. So we have this patient, Mr. T. His age is 69, and he was admitted in Verona for a non-ST elevation MI. As you may see, so there is a severe stenosis on the ostium left main. At that time, so there was the Excel trial, so the patient was invited to accept, and he did. And he was randomized to PCI with the everolimus eluting stent according to the protocol. So the PCI was done so quite in a simple way, so with a provisional stenting of the left main towards the circumflex, one single stent. After that, so there was done POT, so kissing balloon, as you see here, and final result was quite acceptable, so I will say great, so with a good result, so without any problem. So as you know, things in medicine are not easy, and then the patient was uneventful during 11 years, and then he returned again to our hospital for dyspnea. So at this time, so the patient was 80 years old, so the first time that we saw was a 69. And in July 2024, so there was this severe aortic stenosis, as you may see there, with a preserved left ventricular function. So at that time, of course, so the status of the coronary arteries was checked, and as you see here, so there was a angiographic moderate restenosis on the ostium of the circumflex. So Flavio did the FFR of the LAD, which was negative, 0.93, and he did as well the FFR of the circumflex, which was negative as well. And then, so the procedure so was quite straightforward for TAVI. So you see there, so there was an election for a balloon expandable valve. And after that, so the flow was improved in the circumflex. And I must say that the angiographic stenosis is even less than before the TAVI implantation.
So, Salvo, this is a history of 11 years of a gentleman becoming old, I mean, arriving at 80 years old, without events. I mean, no need for revascularization, no MI, normal ejection fraction, and his natural history brings him back to the hospital because of the progression of aortic stenosis. So it is good that he had a stent. I mean, he didn't have a mammary, it would have been a problem in case of an operation, or no need because he was a candidate for TAVI. In these cases, stents are performing very well.
Exactly. In this case, so stents were performing very well. So the patient stayed, as you said, 11 years without any events. And then, so of course, so there is a progression of disease. In this case, it was not a progression of the artery, but was a progression of the aortic valve.
Okay. It's a short lesion. It's a bifurcation treated simply with provisional stent. It's a big stent, and it was implanted under IVUS guidance because that was the protocol of the study of the Excel study at that time. So it's performing almost like a mammary artery. This is the dream of all the interventionalists. 11 years of uneventful follow-up.
Yes, exactly. Actually, if we look at the data, so the osteo left main are always, I mean, the same outcome as a mammary artery on the LAD.
Great. So thanks God, we have stents. We don't want to get rid of them, but we can do better in other scenarios. So now I handle to Piera. Piera will show a totally different situation.
Absolutely, Flavio. This is a case of a young man admitted in your hospital, actually, for an non-ST elevation MI, and the angiography showed a right coronary artery without significant disease, while there was a very severe disease in the proximal LAD. Also, LAD, as you can see, was involved by a very diffuse disease from the very proximal segment to the distal segment. So, in 2014, when you performed this case, what were the options? One option was surgery. That was not good for these patients because really there was no ideal segment where to implant the mammary artery. So you had two options, the full plastic jacket and the full metal jacket. But you did not choose this aggressive treatment, and you choose a more delicate and less aggressive PCI, consisting in the combination of BRS, bioresorbable scaffold, and drug-coated balloon. This combination can be defined by BIO PCI. And let's see the treatment you performed. This is the pre-procedural IVUS after a balloon dilatation with a 2O balloon, showing a diffuse plaque from the proximal to the distal segment. The plaque was not so calcified, so guided by IVUS, you decided to implant a BVS in the proximal lesion and to treat all the other segments, the most proximal segment and the distal segments, with the 3-coated balloon. So you did an LAD bioreconstruction with BRS and with drug-coated balloon. This is the post-procedural IVUS, confirming a good expansion of the BVS and also confirming a good luminal area in the segments treated by the drug-coating balloons. After 5 years, the angiographic results is really very good. The artery is clean, there is no metal there, and really there is a positive remodeling, but the artery is very good, and the good results was also confirmed by OCT, showing the disappearance of the strut and a good area also in the segments treated by the drug-coated balloon. After 10 years, the patient is without events. So Flavio, you performed really a BIO PCI, but do you want to explain us better this concept?
Yes, well, Piera, you already introduced the concept. Bio means leaving no waste, leaving no debris, something you cannot recycle. Mm-hmm. And this is very unfashioned. I mean, this is in the future of our planet and our life. So philosophically, what we try to do in these very nasty anatomies, which are not good for stenting, is to be good to the patient. So keep the procedure simple and use as less as possible contrast. And be good to the artery. And to be good to the artery, you have to be patient, you have to be delicate, or nasty if needed, but to obtain a good vessel preparation, reducing as much as possible the quantity of metal. That, as we said before, sometimes is necessary, but when it is not, we will try to avoid it. I state for intervention without permanent foreign bodies. We will see that in the next slides, which are the reactions at the long term of metal that could be, at least in part, prevented by the use of bioresorbable technologies. And O states for optimal medical therapy. Optimal medical therapy has done incredible progresses. No one can deny the effect of that on top of PCI, or rather PCI on top of medical therapy, and of course teaching our patients the importance of a healthy lifestyle. If you put all these together, we will try to start thinking about a different way of performing percutaneous revasc in a biocompatible way. But Piera, which alternatives on top of stents, what can do a BRS technology better than the metallic stents?
Actually, there are several advantages related to resorption of a coronary device. First, by totally engaging the vessel, vasomotion, shear stress, and vessel shape will be restored, thus re-establishing the vessel function. Second, when struts disappear, there is no substrate for malapposition, for fracture and thrombosis triggering adverse events. Third, there is the possibility for angeling side branch in bifurcation. Fourth, an interesting positive effect of BRS is that related to the avoidance of late inflammation, thus potentially reducing the developing of neoatherosclerosis. And finally, the tissue produced during the resorption process can lead to plaque sealing and passivation. So thanks to these advantages and based on these advantages, several devices were developed. But the first generation BRS mostly used in clinical practice were two, Absorb BVS and the Magmaris. One was made in plastic and the other one, the Magmaris, was made by metallic element, the magnesium. And these two materials have different properties. In this, the magnesium has a higher mechanical strength than PLLA, but most importantly, the magnesium is a material with a very low thrombogenicity. So both devices had thick struts, about 150 micron, and both provided a quite short scaffolding time, about 3-6 months. But the big difference between the two devices was the resorption time, which was very long for Absorb BVS, about 3 years, and it was shorter for Magmaris, about 1 year. And this difference in the resorption time is very important because, as I said, there are several advantages related to resorption, and also we really want to see the vessel healing at an optimal time after resorption, and the vessel healing after Absorb BVS occurs even later at 5 years, as shown in these very nice OCT images, which also are very suggestive of plaque passivation after Absorb BVS implantation. Finally, BRS may offer the opportunity for improved future option for repeat revascularization, thus allowing for a better management and treatment of complex multivessel disease. Also, BRS would allow for a better use of non-invasive imaging during follow-up. And finally, BRS eliminates the patient concern about having a permanent implant in their coronaries for the rest of their life that, as you know, is really a concern for most patients.
Okay, Piera. So you have told us which are the potential benefits of this fascinating technology that was already tested in clinical practice. Then it had a stop, and now we are trying to understand whether there is a future, if there is a position for that. The question is, if there is a position for BRS, why? Salvatore, why do we need something different to conventional drug-eluting stents that, as we said, perform very well in certain situations?
Exactly. So in some situations, drug-eluting stents perform very well, but in some, they are not good. and especially if we look at the BIO PCI, so what we want to achieve is to not have an image like that, so where there is a metal inside the vessel, and they will be there forever, and as you may imagine, so this image is coming from a patient from the anatomical scenario. So let me make a summary of what we have learned from the past. So first, data are coming from the 3 years outcomes of the Absorb 3 trial. As you may see, and you may remember as well, so the Absorb get a higher rate of TLR, target vessel MI, and also device thrombosis as compared to everolimus routine stent. So this was in 2018, and after that, so there was a call for a refined, improved technique implantation. You may remember the so-called PSP, where the first P stands for predilatation, so for an accurate preparation of the lesion. Second, the S stands for sizing, so for a correct sizing of the vessel, so if you want to implant a 3.5 or 3.0 scaffold. And last but not least, so the last P was about the post-dilatation. So that means to post-dilate as much as we can, so the scaffold which was implanted, in order to avoid the animal position and to have also a good stent expansion. Based on this PSP, so the new trial was the Absorb 4. So in here, I will show you the 5 years outcomes, and as you may see on the bottom of this slide, the target lesion failure was still in favor of the metallic stent, so the everolimus routine stent. But looking at the last column, so you see that after 3 years, especially between 3 and 5 years, there was no actually one over the other. So the two scaffold and stents were performing at the same way. Same results, so were coming also from the AIDA trial. The AIDA trial, so as you remember, was testing the Absorb versus science in an ACS population. And again, here you see that at 5 years there was no difference in terms of events, but looking at it from 0 to 3 years, so there is a huge difference, especially in terms of stent thrombosis, favoring the everolimus routine stent, so the metallic one. But after 3 years, so between 3 and 5 years, there was no much difference between the two platforms. So coming now to the McMurray's, so for the McMurray's clinical trials, so we have this data coming from a different registry. And you see that at different times of follow-up, so the rate of these events were quite acceptable. So especially the scaffold thrombosis was extremely low, so 0.8 all in the bioresorbable 4. And I can tell you that there was a reason at the base of this low rate of scaffold thrombosis. So there was actually a very elegant trial, a very elegant study published on circ intervention, which was showing the low thrombogenicity of magnesium-based scaffold, as you may see here, in terms of platelet adhesion as compared to the Absorb. So the platelet adhesion was much less in the McMurray's as compared to Absorb. And this is maybe the base of this low thrombogenicity of the McMurray's first generation. But anyhow, so there were also some problems, some cases of failures. And you may see here, so one example of other cases already published and known. So where you see that there was some discontinuity in the middle of the scaffold, showing at the third square on the bottom, that you see that it looks like a collapse of the scaffold because maybe of the early reabsorption, and then the scaffold is in the middle causing restenosis, but not thrombosis in this particular patient.
So, Salvatore, we went through the potential advantages that Piera explained very well, and you addressed which are the shortcuts of the past technology that are putting some limitations to this idea of finding this optimal device. These are related, as you said, to the technique of implantation. It seems that after following accurate technique, using probably imaging, the results became better compared to the initial, and others are related to the material itself. You said, Piera, that the reabsorption time of Absorb was a little bit too long, and probably this may explain this toll that patients had to pay of this high rate of thrombosis during the first 3 years. But in the end, when the thing is gone, with the two different devices, the long-term follow-up becomes almost as good as the metallic prosthesis. So these are the two things we have to consider. One is the operator, one is the technique. There is no equalization. There is nothing like direct stenting with these devices, good vessel preparation, medical therapy, and then technology that it's improving the results, and this is what we are going to see in a moment. But I want to go back to our people staying behind the screen to ask them to make questions. They are warming up. They are just saying hello. People saying hello from Kenya, from Armenia, from Mexico. Okay, we are very happy about that, but we want also your questions. So we are here to answer your questions, and now I see the first two questions arriving. You said there was an issue with the rapid reabsorption of the magmatis, and there is a kind of collapse of that. And this has to be, as we said, with the material, but also with the implantation technique. Which are the features that we need to obtain the optimal design of this device, Salvo?
Yes, so as you may see here in this slide, so I tried to make a summary of these features. If we may ask to someone to make the perfect, or what could be the perfect BRS, so we may ask for all these different features. So I would like just to highlight to you, so the ones to me which are more interesting, which on one side is the thin struts, so we don't have to forget that in the first generation we were dealing with the 150 microns, and these 150 microns were per side, so meaning that just by implanting a BRS, so you are creating a late loss of 0.3, because of course you have to consider that the vessel is circular. And the other important characteristics are to me, so a good balance between the scaffolding time and the reabsorption time. So you need something that is able to scaffold as long as, so you get the reabsorption, in order to avoid on one side the collapse of the scaffold, on the other side also to get the material out of the artery, and then so you avoid any problem at the later stage.
Good. So before we move forward with an example of an almost failure of the device because of a bad implantation technique, I want to address one of the questions that our colleagues sent us, which is very important and appropriate to this point of the discussion. How much does it lack the optimal medical therapy effect of the expected result? I will address this question to our friend, colleague Iglesias, who is on the other side of the screen, because Juan, how important it is for the patient to be compliant with the therapy to stay safe and effective in this BIO PCI philosophy?
Well, Flavio, thank you for the question. I think this is an important point because we are talking here about technology, about operator skills and knowledge about how to implant these devices. But at the end, we have a patient. And we have experienced in the past several cases where we did our best by implanting the good device, providing a good lesion preparation and an optimal result. But at the end, this is really important to inform our patients and make sure that they are first compliant with the medication, but as well that they take care of the coronary arteries by health style management, because this is of paramount importance. We are talking about some kind of general disease. We are treating the focal lesions, but we are not treating the overall disease without the patient. So I think this is an important point, and this is part of the discussion. We can provide some biotechnologies respecting the artery, but at the end, we need also to respect the overall disease, and the patient is a very important part of this management.
Absolutely. The control of hypercholesterolemia, but even more important of hypertension, and very important during the reabsorption time, the dual antiplatelet therapy. So this is not a kind of device that we will consider in high bleeding risk patients unless you keep without scaffolding and you treat these patients with only drug coating balloons. So very good point. So I hope the colleague Jorge Eduardo Chavarriga is happy with your answer. I think he should be. And now we go back to a case which is what I call an almost failure. This is a case of a young patient we treated in Verona some years ago. You see it's a dominant circ and a quiet simple lesion on the proximal mid LAD with a lesion that seems to be, not so tight and not so long. So my question to the panel, but in the meantime, to those attending the webinar is, would you treat this lesion with BRS? We are trying to identify an indication for these devices and this philosophy. So the question goes to you guys. Answer one if you think this can be a good patient for a BRS, or no if you think it is not. And I go quickly through the panel. Piera, do you think it's a good case for a BRS?
Yes, Flavio, because we'll tell you why. Because it's a simple lesion. It looks like not calcified by angiography. And I would go straight for a BRS without imaging in this lesion.
Straight does not mean direct.
No, straight,
Okay.
the choice.
Salvo.
I agree. I mean, the patient is young, so it's a typical patient that you put a stent and thereafter, so he asks you, so I have to come back because you have to change my stent, or this stent will stay there forever.
Okay.
And then, so as Piera said, so the angiogram looks without calcium, so not, I mean, a very difficult lesion a priori.
Okay. Juan, would you treat these patients with a BRS?
Yeah, I fully agree with my colleagues here. We're talking about a young patient with a quite short focal lesion on the LED. That's typically, I mean, the kind of patients that may benefit from this technology of bioresorbable technology, provided you may achieve a good lesion preparation, which is probably one of the
because
issues.
of course this is also a good case for a stent. I mean, it's a 3.5 vessel, less than 20 millimeters, single vessel disease. So I think there is nothing wrong putting a good drug-eluting stent. But what we did was, first of all, of course, assessing the physiology. The lesion is ischemia-provoking. The FFR is 0.77. And you see in the pullback, it's a focal lesion, so it's ideal for PCI. And this is what the operators did. But to his surprise, you see that after multiple dilatations with semi-compliant and non-compliant balloons, you see the 3.5 non-compliant balloon, it is not well expanded. So despite the angiography is not showing particularly calcified vessel, there is something on that making the resistant lesion. We will argue, we will discuss whether the decision of going with the stent, which is not a stent, it's a scaffold, it's a good decision. Apparently it is not, because the image you have on the right side of the screen is showing a perfectly clear under-expanded BVS, which is a bad thing. So at that point, the operator said, wow, there is something is not working, and kept on trying to dilate with higher pressure and bigger balloons. But you see that there is still an important residual stenosis. This is a very important concept. We should never leave on a bioabsorbable device with this angiographic result, and even less if it is obvious at the intravascular imaging. So the next step was becoming, as I said, more demanding with vessel preparation, and this is a totally off-label use of IVL, but it's a very effective use of IVL, followed by a non-compliant balloon at 4.5 millimeters, and you see that now the scaffold is well expanded. So at this point we will check with both physiology and IVUS to make sure that the scaffold is well expanded, that there are no big dissections. So this is a risk of almost failed. I mean, if you see this case after 1 year with a collapsed BRS, I think it's not the fault of the technology, it's the fault of the strategy. But to make sure that we did a good job, the patient was called electively after 1 year because he was included in the national Italian study. And you see that there is a positive remodeling, there is a very nice result at 1 year after the BVS. So what does this mean? I mean, which is the teaching point of this case, Salvo?
Yeah, to me the teaching point is that, so we say the PSP, no? In this case, the first P is the utmost importance, no? Because the preparation is the key. So once we see that the 3.5 non-compliant balloon doesn't expand, that there's a waste, so personally I will not go directly for a McMurray or for a BRS in general, but anyhow, so you solved really well the problem. Yeah. And second also, so it's good that you check with the IVUS after the implantation and after the IVL that the stent was good, so without any major mechanical problems. So that could be, I mean, a cause of any events during the first year. So I guess that everything was good. Preparation is the key, and checking if you have some issue with the imaging also is a good choice.
Yeah. So it might happen that even in apparently simple lesions, there is some fibrosis, some resistance, and these devices require accurate and delicate treatment. Be good to the artery. Okay, so there are other questions arriving, but in the meantime, I will share with you the opinion of our colleagues. 80% of people thought that this was a good case for a BRS, while there is still a 20% of people that think that probably a regular stent would be fine. And I am among those. I mean, I think that there is nothing wrong in implanting a good drug-eluting stent on that case. I will ask you another, colleagues are asking whether the case that you showed, Piera, with this bio combination of bioabsorbable scaffold and drug-eluting balloons was treated with paclitaxel or sirolimus eluting balloon.
Yes, it was treated with the paclitaxel eluting balloon. And,
Juan, you are an expert on this field. Is there any concern on mixing paclitaxel with limus drugs when you use, for instance, the Freesolve? The Freesolve has an elution of sirolimus, if I don't go wrong. But you, in that case, would you select for your BIO PCI strategy a sirolimus eluting balloon, or you don't have any issues in mixing the two drugs?
Well, I don't think that we have any data suggesting that we are causing harm by mixing the two anti-proliferative drugs. You know, this debate is coming back to the era of Cypher and Taxus, where we were thought not to mix both stents, provided that they have different anti-proliferative drugs. But to be fully honest, I mean, we have now quite large experience mixing both with drug-eluting stents, most or less everolimus or sirolimus, and paclitaxel eluting stents, and we didn't see any kind of problem.
I agree. I absolutely agree. There are many questions arriving, so I go with short questions, short answer. Salvo, would IVL risk damaging the scaffold?
Sorry, say it again.
The IVL, the case
IVL,
we showed, would this might potentially damage the structure?
Yeah, again, so there are no data, so specifically on that. So if I have to do a short answer, so I will say no, because when we use, for example, for a metallic stent, so not made of magnesium, so there are already data showing that there is no risk of damage. But for Bagmaris, so we may apply the same, but there are no data.
Okay. Another question, is it appropriate to use, for instance, cutting balloons for vessel preparation? The question goes to Piera. And the second part of the question is using cutting balloon inside the BRS, and this will go to Juan. Piera.
But I think yes. I think there is. It is a good tool for lesion preparation, especially in fibrotic lesion. This is my experience.
Juan, any concern in putting a cutting balloon inside BRS?
Well, to be honest, I do not have experience. I try to achieve the best lesion preparation beforehand. And as Piera said, I think it's very highly important to use these kind of cutting devices. I mean, what we know from the BVS experience, but as well from the primary experience with the Freesolve in BioMag1, is the more fibrotic tissue you have at baseline, the more late loss you will have at 12 months. So it's very important not just to take care about what is calcium, but also what is fibrotic tissue, and make use of these devices to cut collagen tissue before implanting the device. But then afterwards, I have to say, I do not have personally any kind of experience in using these devices in bioresorbable scaffold. I think the work has to be done before implantation.
I think this is the perfect answer. We are talking about good lesion preparation before opening the parcel of the BRS. And your message is very clear. You shouldn't run after the, let's say, complication or the unhappy result of having this BRS not expanded, like in the case I showed, but it's the same concept for a metallic stent. Here you have another concept that the plastic of the PLLA or the metal of the magnesium might probably break more easily than the cobalt chromium structure of a stent. So for sure, the case I showed using IVL after the BRS implantation, it's a kind of bailout, rescue strategy to expand it, but it would have been much better to do it before. And to avoid this use of cutting balloons or IVL inside the, it's still an off-label indication to use this to expand stent, of course, although it is very effective and very safe. So, well, We are now in front of the next step. We have been discussing the results, the studies, the technologies of the bioabsorbable technology as it used to be, with the good and the bad. We have shown that. But fortunately, and this is why we are today here discussing on this topic, there are third-generation devices. So, Juan, you are an expert on the use of the magnesium-based technology. So tell us what's new on this field.
Well, Flavio, as you mentioned, I think we are living a very exciting and promising era in the field of bioresorbable technology with the introduction of the DREAMS 3G, which is commercially known as FreeSolve, which is the third generation and latest iteration of magnesium-based bioresorbable scaffold technology. And as you can see here, based on the clinical evidence that has been accumulated over the last years, maybe my slide will just move forward. Yep. So based on the clinical evidence that has been accumulated with the Magmaris second generation resorbable magnesium scaffold, FreeSolve has been recently introduced to enhance the technological features of Magmaris and try to match the mechanical properties of newer generation metallic drug-eluting stent devices. And there are several goals. The first one was to improve the mechanical properties of the magnesium alloy found in the Magmaris, and this has been and this has resulted in the introduction of a new magnesium alloy called Biomag. Then to reduce as much as possible, as Salvatore said, strut thickness, and we have now a larger matrix of thinner struts with the new device. One of the goals was to maintain the resorption time in order to avoid as much as possible the scaffold collapse that has been reported with the Magmaris resorbable magnesium scaffold. One of the feedbacks of the operator was the radio opacity of the markers of the Magmaris, and this has been improved in the new FreeSolve devices, and I will come back to that. And finally, is to have a larger size portfolio able to accommodate the device in a larger range of diameters and length. So the first improvement in the device was the introduction of a new magnesium alloy. So we know from the Magmaris experience that magnesium provides superior mechanical strength compared to polymers such as PLLA that has been used in previous generation PLLA-based resorbable scaffolds. And with the new Biomag alloy, which incorporates 6.25 weights percentage of aluminum to the magnesium alloy, this has resulted in improved mechanical properties of the device with an increased tensile strength. And as shown here, the DREAMS 3G Biomag alloy degrades with incorporation of water and ions of calcium and phosphate into amorphous calcium phosphate and small amounts of aluminum phosphate. And in animal model, this has been shown to completely degrade within 12 months. But very importantly, and this is one of the main differences between this device and the Magmaris device, despite similar degradation kinetics, this process is more homogeneous, as shown here on the left side, with reduced variability in individual strut degradation. And this is of paramount importance because first, the magnesium alloy with improved mechanical properties as a low reduction in strut thickness. Strut width is still 150 microns, but we have now in the 2.5 device 99 micro strut thickness, 117 microns in the 3.0 and 3.5 scaffold device, and 147 micrometers in the 4.0 millimeter scaffold. So this is coming. So this reduction in strut thickness comes, however, at not a price of reducing the mechanical properties, but at improving them with a higher radial strength, as we will show later. The second important feature here is, despite the change in the magnesium alloy, the resorption time is maintained similarly as the one that has been previously described with Magmaris. And here we have the results of a BioMag-1 intravascular imaging sub-study showing that at 12 months, 99% of the struts in vivo were invisible. So this shows that we have the same resorption process as compared to Magmaris. But very importantly, during this resorption process, the introduction of a new magnesium alloy like BioMag provides a longer radial support over time, and you see less discontinuity density as shown here on the right-hand side when compared to Magmaris. And this provides a prolonged radial support to the device as compared to its predecessor. One of the things that was mainly for some of us a drawback at the time of implanting and optimization the scaffold results were the lack of visibility of the device. And now in FreeSolve we have not two but one oval tantalum marker at each end, and as you can see here on the right hand side, with improved radio opacity, allowing for facilitating an accurate placement of the device and the positioning of the post dilation balloons within the scaffold. And also one of the important features is the expansion of the size matrix. We have now 13, 18, and 22 millimeter length device in 2.5, 3.0, 3.5, and 4.0 scaffolds. The 3.0, 3.5, and 4.0 scaffolds have also length from 26 to 30 millimeters. And in the near future, these larger devices will have length up to 30, 35, and 40 millimeters. And definitely this will increase the potential number of lesions that could be treated with this scaffold. So the safety and efficacy of this FreeSolve scaffold has been investigated in the BioMag-1, which was a prospective multi-center single-arm study. And as you can see here, we are shown the results, the angiographic results at 12 months, showing in-scaffold late loss of 0.24 and in-segment scaffold, in-segment late loss of 0.1, which were 38% and 60% lower than those that have been previously reported with Magmaris in the BioSolve 2 study. And very importantly, these late loss data are very close to those that has been previously shown with metallic stents, newer generation drug-eluting stents. And this is the rationale that serves to test now this device in a dedicated randomized head-to-head trial against a newer generation drug-eluting stent. Here as well, despite the study was not powered for clinical endpoints, you can see here very reassuring safety data at 1 year with 2.6% rate of target lesion failure, which was mainly driven by 3 cases of clinically driven target lesion revascularization. But very importantly, at 1 year, none of the 117 patients that have 16 patients and 117 lesions that have been treated with the scaffold presented with scaffold thrombosis, and this highlights the safety of the device. As mentioned previously, these preliminary data were very encouraging and serve as a rationale to design the first head-to-head randomized clinical trial comparing the FreeSolve device to a contemporary and widely used newer generation drug-eluting stent. And this is here the study design of the BioMag-2 prospective multicenter international randomized controlled non-inferiority trial that will include 1,859 patients with de novo coronary artery stenosis. These patients will be randomized in a 2-to-1 fashion to FreeSolve resorbable magnesium scaffold or the Zyme everolimus eluting stents. This patient will be followed up annually up to 5 years, and the primary endpoint based on the non-inferiority hypothesis will be target lesion failure as a composite of cardiac death, target vessel myocardial infarction, and clinically indicated target lesion revascularization at 12 months. This is the slide showing the participating sites. This is a very ambitious trial that we include 100 investigational sites across 21 countries in Europe and in Asia Pacific. And we had the opportunity to include the first patient back in May 24 at Geneva University Hospitals. And here you can see the enrollment status as of last Friday, December 6. Up to date, 212 patients out of 1,859 patients have been included across 20 sites and 7 countries. So this is a very important trial, and we hope that these results will reshape the way we are treating patients with single and de novo lesions. But very importantly, this study will include patients with lesion length up to 28 millimeters and a reference vessel diameter of 2.5 up to 4.2 millimeters. And this is probably one of the main limitations here of the percutaneous coronary approach using metallic stents that is still representing a main challenge in routine practice, is treatment of long and diffuse coronary artery lesions. And as you can see here, treating lesions with more than 40 millimeters stent length provides an increased risk of target lesion failure with an increased rate of up to 2-fold at 2 years of follow-up, as shown in its very large patient-level pool analysis of 5 Korean DES registries encoding more than 1,700 patients. And this is mainly driven by an increased risk of target lesion revascularization up to 2-fold, but as well of stent thrombosis up to 2.5-fold among patients treated with long stent segments more than 40 millimeter length. And that's why making use of this BIO PCI approach, combining the best of a resorbable magnesium scaffold to scaffold as short as possible the vessel, and combining this with a newer generation drug-coated balloons, in this case paclitaxel-coated balloon, we designed the BioHybrid pilot trial, which is an investigator-initiated prospective and multi-center randomized controlled trial, which aims at compare in a head-to-head trial this hybrid PCI approach combining free solve and at least one paclitaxel-coated balloon versus conventional DS-based PCI using the Orsiro stent among 142 patients with de novo long and diffuse coronary artery disease undergoing PCI. And we're talking here about patients, as mentioned in the previous slides, with more than 40 millimeter at least total stent length. So this is a pilot trial aimed at demonstrating the concept. The primary endpoint with a non-inferiority hypothesis will be the vessel level absolute change in non-invasive angiography-derived fractional flow reserve between the post-PCI, index PCI, and 12-month of follow-up, assuming that the restoration or the preservation of coronary physiology at 12 months would be higher among patients treated with an hybrid approach as compared with those treated with a DES-based approach, owing to the risk of late loss and therefore a restenosis. So as I mentioned here, so this slide here will summarize the main inclusion and exclusion criteria of our study. If it moves, yeah. So patients with stable or unstable coronary artery disease with a target vessel reference diameter ranging from 3.0 to 4.6 millimeter and a total lesion length of more than 40 millimeter will be included. And we will have more or less the same exclusion criteria, those that are currently using the BioMac2, so excluding bifurcation lesions, lesions with excess tortuosity and heavily calcified lesions, and those with unsuccessful lesion preparation. So we plan to include the first patient in Q1 25, and we hope to provide this data to the community during Q1 26.
Okay. Thank you, Juan. Very interesting to see all what's new behind this technology, that it's absolutely not abandoned. There are some questions coming from our colleagues. Very short answers. One, it's quite obvious. Is it safe to perform MRI studies in a patient recently implanted BRS with magnesium?
I think it's for me, yeah. I don't know if my colleagues have the answer, to be honest. I was not aware of any kind of contraindication. We do it regularly, I mean, for non-culprit lesions that are previously treated with the BRS, and I mean, we didn't have any kind of problems.
I regularly perform MRI for patients getting metallic stents, so I think there is no concern about that. Another interesting question is whether the company is planning to develop bigger stents that could be implanted in bigger vessels, like the aorta or the pulmonary circulation. Are you aware about that?
Not personally. I mean, the developments now are going towards longer devices, and you will be part of this first-in-man study starting very soon with a longer length, but I'm not aware personally of larger devices.
Yes, indeed, we will be participating in Europe to the BioMAC2 long lesions, which is indeed a registry implanting very long scaffolds. We are much looking forward to start before the end of this year. And well, you gave a very nice update, but now we move again to real life. So I will ask Salvo to present the last case of this afternoon, which is a real BIO PCI approach at the long term.
Yes, exactly. So let's go back to the clinical practice. So I will show you this patient again. So we are making a sort of history back. So we are back in 2015, and we received in our cath lab. Actually, this was the cath lab of you, Flavio. So this patient of 49 years old with stable left aortic angina, and usually so we see this diffuse critical stenosis of the right coronary artery. There was an occlusion on the first marginal branch, and there was this diffuse, no critical LAD disease. So Syntax score you see over there, and then the decision made at that time was to perform a PCI, so with this concept of a BIO PCI. So you did a PCI of the right coronary artery by implantation of 2 absorb, because at that time there was just absorb, so you use a 3.528 and 3.523. And then the same concept was applied also to the circumflex, where there was just 1 absorber implanted of 328. Everything was guided by imaging, as you may see here, by IVUS with a good achievement of minimum stent area and also a good achievement of expansion. LAD at that time was also studied by IVUS because IVUS was already open. And as you may see here in this slide, minimal lumen area was fine, so was 4 millimeters square, but there was a huge amount of plaque, so something that we may call the finca fibroateroma. And at that time, there was a decision of having an optimal medical treatment of this patient by using the best medical treatment as possible at that time. So the patient came back 5 years later with worsening angina. And as you may see there, so the right coronary artery was still with a great result. So there was actually no remnants of the bioresorbable scaffold implanted 5 years before. On the circumflex, there was also a good result with some positive remodeling, as you may see there in the mid portion of the vessel. And then going on the LAD, so there was actually a progression of this disease, of this atherosclerosis disease, because of the natural story of atherosclerosis. So it was confirmed by FR that it was positive. There was a huge amount of plaque, again a fibroateroma. And at that time, Flavio and his team decided to treat this patient with the implantation of 2 Magmaris stents at that time. So there was just the Magmaris, so 3.525 and 320 with a good again BRS expansion of 90%. So everyone will say that everything is done, but at 1 year later for an elective follow-up of this patient, just to be sure that everything was fine. Indeed, it was fine on the LAD. But looking at the circumflex, and when we compare the result from 2020 to the result that we have just 1 year later, so not much time after, so you see that there was this severe restenosis in the distal part of the previous implanted stent. The patient was totally asymptomatic at that time. So, and that because of the symptomaticity of the patient, angio-based FFR was done. Just to confirm that there was a FFR 0.42. So we came from a positive remodeling to subocclusive stenosis, which is something quite funny when we talk about atherosclerosis. And again, the patient received a Magmaris in this case, and now in October 2024, the patient was asymptomatic. So this is to me the typical, the good example of a patient that in all this story, was kept without any piece of metal. And also, the team would treat this patient was always with the same philosophy of the BIO PCI, because at some point we may have some thinking of having a piece of metal in this patient.
Yeah. This is really a nice demonstration of how following a patient under medical therapy, it's a young patient, he's still working, he exercised, but despite all that, there is some genetics, on his corner is which are not so nice. The good news for him is that their corners are still naive. There is no metal in case he wants to undergo surgery or in case he will develop a very calcified tight lesion, he might benefit from a strong metallic stent. So it's a good example of how managing this bio philosophy in a young patient may be rewarding on top, of course, always of medical therapy. So it's a very nice example of what we wanted to share with you today from the studios with our colleagues. There are other questions coming here. One is for Juan. Juan, a colleague says one of the metabolites of the reabsorption of magnesium is hydroxyapatite, which is one precursor of the calcification of the vessel. Has it been shown that after reabsorption of the magmatis, the vessel becomes strongly calcified?
I mean, not from to my knowledge. I mean, we have now quite long follow-up in several patients, including with even previous generation of these devices. And as far as I know, I mean, this has never been described.
Okay. The question here, I think, is difficult to answer. Have you any experience with other BRS except Abbott and Biotronic? I mean, the colleague is mentioning other devices that I think were Phantom, Encore, Reva Medical, with showed lower TLF through 5 years. That any one of you guys have experience with other devices?
I don't, Flavio.
No, I don't have any experience on treating patients with these devices. I know the data, but so these data are coming not from big evidence. So what we need is a stronger evidence to be sure that so we are treating the patients with the good devices.
Piera, I know you are aware, but the results, I think were published in the New England of a return of bioabsorbable PLLA scaffolds in the peripheral circulation. Can you comment briefly on that?
Yes, Flavio, the device is the BTK, Esprit BTK, which is an everolimus eluting resorbable scaffold with 99 micron of struts thickness. And it was approved very recently by the FDA for a peripheral artery disease below the knee. And this approval was really based on the positive results of the LIFE BTK trial published in the New England Journal, showing that the Esprit BTK, everolimus eluting resorbable scaffold, was associated with better one-year outcome compared with PTA for the treatment of a PAD below the knee. So it is an evolution of a PLLA-based scaffold eluting everolimus. But I don't know about other new generation devices.
There are studies ongoing, but the message we wanted to transmit is that the technology is making slowly but steadily progress, and there is room for improvement. So we have 3 minutes left to end our meeting today, and I think we have gone through most of the curiosities that we all have related to this topic, and so we can go to the conclusions of what is this concept of biohybrid PCI. We explained it quite well, but what we want to underline is the need for something different where it is really needed. We want to underline that new generation drug-eluting stents are very effective in many different scenarios, but there is nothing like full metal jacket being, let's say, in the context of modern interventions in the coronary artery, thinking especially in people that have a long life expectancy. We don't want to pave these arteries forever. This has been, the enthusiasm of 30 years ago when stents came up, but not even the stents with drug-eluting provided good results on that. There is in the middle, the reasonable stenting, which is what we have been showing. The case that Salvo showed in the left main is just one example, but there are many. And on the other side, on the extreme right side of this rainbow, we have what should be the ideal behavior, especially for modern generations that have to behave in a biologically and environmentally correct world, because we are really risking not to lose only the coronaries, but losing also the planet. So this biophilosophy should be part of our daily life. And in the coronaries, leaving nothing behind, that was one way of saying, or just leaving what is necessary, but avoiding what is unnecessary and with time becomes waste or debris, is what we want to transmit to you today. Of course, the association of a scaffold when it's needed because the lesion is resistant or because there is a dissection that sometimes scared is a very good companion to the drug-eluting only policy, which is a very good companion, as Juan showed in his study, the biohybrid study. So if there is time for some final comments from you, otherwise we will say goodbye to our comments. Salvo, Piera?
Flavio, my final comment is that I liked very much our discussion because we have highlighted the good, the bad, and the ideal of the VRS technology. And now, as you said, we have a tool as FreeSolve that has some ideal characteristics to give us a new chance for BRS technology, but also to give us an opportunity to perform a BIO PCI, as we have said, that includes devices, but also medical therapy, as we have said. So I really appreciate and thanks for involving us in this very interesting
Thank you, Piera, for this last word. I think it's time to say goodbye. We just wanted to share with you something which is probably in the future of our interventions. We insist that this is a concept that we need to transmit to the new generation. I want to thank Piera, Juan, Salvo, Biotronic, Europa, and PCR, and all of you who were connected for attending this. Remember that you can go back and see the recorded version at the PCR website. Thank you very much for being with us, and see you at the next PCR webinar.
Thanks.